Hello everybody. So changing tack a little bit, I'm going to be talking about medical therapies following on from the surgical talk, and particularly focusing on new and emerging therapies rather than sort of what is already fairly well established. So I'll be covering some of the therapies for acromegaly, Cushing's disease. I'll briefly touch on craniopharyngiomas, and then some of the newer treatments that are under investigation for aggressive pituitary tumours. So generally, I think we've sort of covered this already, but goals of treatment, of course, overall in pituitary tumours are to reduce the tumour size or eliminate tumour size and hopefully get a cure, and also to normalise the biochemistry in functioning tumours. As we've heard and discussed, surgery is mostly first-line treatment for all tumours, apart from prolactinomas, although there are exceptions. If we consider surgical cure rates, the acromegaly numbers I've put up there are local. That's at our centre, which is comparable to the international rates. So around 70% for microadenomas and less for macroadenomas. Cushing's disease up to 70%, non-functioning adenomas up to 70%. And so then the question is, if surgery is not curative, what are our other options? And as Mark said, further surgery is potentially an option, and then we go on to things like radiotherapy and medical therapy. Indications for medical therapy in acromegaly may be persistent disease post-operatively, so when a surgery hasn't resulted in a cure, or less commonly as primary therapy if the patient is considered to be a poor surgical candidate. And the treatments available to us at the moment are somatostatin receptor analogues. So if we look at this little diagram here, the hypothalamus stimulates GHRH to stimulate the pituitary gland to produce growth hormone, which then has its actions peripherally in the body. This is under negative or inhibition by somatostatin, which acts on the pituitary to reduce growth hormone secretion. And what the medications that we use do is similar to somatostatin, they're somatostatin analogues, and they reduce the growth hormone secretion. And we've got a few available options. Octreotide, lanreotide are fairly commonly used. Peptide is the most recent option, and that's an intramuscular 4-weekly injection, otherwise known as Signifor. Peptide is different from the octreotide and the lanreotide in that it actually has action on a greater number of somatostatin receptors in the tumour. So octreotide and lanreotide have action particularly on somatostatin receptor 2. This is an illustration here of a tumour cell with the multiple different receptors. So there's 5 receptors. Lanreotide and octreotide act mostly on receptor 2, whereas peptide actually can act on all of them, particularly number 2 and number 5, which are the most prevalent in acromegaly. So slightly different from the other options available. Peptide normalises the IGF-1 in up to 35% of patients, which is greater than the effects seen with octreotide. The main adverse effects and what can be a real problem with peptide is hypoglycemia, which can occur in up to 30%. And patients with pre-existing diabetes, this can be a problem. It can induce hypoglycemia in people who haven't previously had it, so that's something we need to monitor and potentially requires treatment whilst patients are on peptide. In terms of the PBS criteria, this is now on the PBS. So patients can qualify if they biochemically have active acromegaly, so their growth hormone is elevated, IGF-1 is elevated. The treatment with peptide can only be given after patients have been on octreotide or lanreotide, and that has not been successful. And this treatment, peptide, must not be given in combination with pegvisomant, which I'll talk about in a moment, which is another potential treatment for acromegaly. Pegvisomant, differently to the somatostatin analogues, actually acts on the cells in the body that are stimulated by growth hormone. So rather than stopping growth hormone production, it stops the action of growth hormone in the tissues, in the muscle, in the liver. So this is another illustration here. We've got a cell here with a growth hormone receptor. Under normal circumstances, the growth hormone might activate this growth hormone receptor to produce its usual effects. But what pegvisomant does is actually bind the receptor and compete with the growth hormone activity. So it stops the effect of growth hormone in the tissues. Because of that, it doesn't actually target the pituitary tumour itself. So there may still be ongoing growth hormone hypersecretion, and there isn't an effect on the actual tumour in terms of tumour growth and things, but it does improve the effects of the high growth hormone by stopping the effects in the peripheral tissues and the production of IGF-1. In the pivotal trials, there was actually normalisation of IGF-1 in up to 95%, which is really quite incredible. In reality, it's more like 60-65%, and that probably reflects real life situation where there's issues with adherence, variability in the types of patients that are taking this and all those sorts of things, but still very effective. And unlike octreotide, there isn't an issue with hypoglycemia. So PBS criteria is similar to octreotide in that obviously you have to have biochemical signs of active acromegaly. The patients must have had octreotide or lanreotide and failed on that treatment and had ongoing acromegaly despite that treatment. And this treatment can't be given on the PBS with a somatostatin analogue, but this is an option now for people. Third thing I'll just mention in acromegaly is the development of oral octreotide. So our treatments have previously been injectable therapies. Octreotide hasn't been able to be given orally because of previous preparations have had poor intestinal absorption, but there's been development now of newer forms of octreotide which encapsulated with an enteric coating that prevents breakdown before it passes into the small intestine. And then there's also development of this certain technology. It's actually called transient permeability enhancer. That's just a certain type of technology that's been developed to coat the octreotide, and it helps absorption. It is looking like it's potentially an option. It's a twice daily dosing. Patients need to be fasting in order to have it, so at least 1 hour before or greater than 2 hours after a meal. There's been a clinical trial which looked at using oral octreotide following injectable therapy. 65% of patients in this trial did have a sustained response at 7 months, and 62% at the end of treatment, which was up to 13 months in this trial. And large majority of patients had improvement in their acromegaly symptoms, even on top of that had been achieved with the injectable therapies. So that's really quite promising. This is just to illustrate that there's ongoing trials at the moment. There's a randomised placebo-controlled trial looking into the use of oral octreotide, so watch this space. That's possibly will be a potential option in the future. So moving on to Cushing's disease and emerging therapies for Cushing's, I've just sort of listed here at the top, I've separated it into where the medications are acting. So treatments for Cushing's might involve central inhibition of ACTH secretion, so in the pituitary itself, or it might be a matter of targeting the adrenal production of cortisol, and there's some medications that affect that. And then finally, glucocorticoid receptor blockade, which I won't really talk about. A number of these are fairly well established. Patients in the audience, perhaps some of you might be on ketoconazole or metyrapone. They are reasonably commonly used for medical management of Cushing's. What I will talk about is some of the newer ones. We're starting with looking at adrenal inhibition. So this is a medication that's in development. It's a Lysyclib or R-roscovatine. Basically, this is based on interrupting the normal cell cycle. So normal cellular proliferation in the body, tumour growth relies on progression through a cell cycle, which I've illustrated here. The different phases of moving through the cell cycle relies on a number of different enzymes and proteins to cause progression through the cell cycle, which then results in cellular proliferation and tumour growth. This medication is aimed at sort of interrupting the cellular cycle by targeting cyclin-dependent kinases, which are required for progression of the cell cycle. It's known that one of these things, called cyclin E, which is responsible for cell cycle progression, is actually higher in Cushing's disease in the tumours, and it's involved in overproducing the precursor to ACTH. So if we can target that cyclin E, then we can sort of halt cell cycle progression and hopefully stop the tumour growth. And that's what this new medication is trying to target. And there is good sort of in vitro early studies to suggest that this might be effective in controlling or shrinking the ACTH secreting tumours, and that it might also shrink the tumour but also cause a biochemical improvement, so reduce the ACTH secretion and therefore reduce the cortisol levels in Cushing's disease. So as I said, in vitro studies have demonstrated reduced ACTH and reduced tumour growth. It's very promising. There is ongoing trials in this area. So once again, watch this space. But that's really quite an interesting area of ongoing research. Moving to targeting the adrenal production of steroids. Here we've just highlighted the pituitary gland produces ACTH, which then stimulates the adrenal glands to produce cortisol. This little diagram, it's obviously very complicated, but it's just to illustrate that the production of the adrenal hormones is all dependent on a number of different pathways, which relies on certain enzymes to produce cortisol in the case of Cushing's. And levoketoconazole is a newer medication similar to ketoconazole, which targets the enzymes in the adrenal gland and stops the actual production of cortisol in Cushing's. This has been investigated, and this came out not too long ago, the findings from a phase 3 trial. And what they did in this trial was put patients onto the levoketoconazole, titrate the dose for an initial period, then patients went on to a maintenance phase for about 6 months, and then an extended evaluation of 6 months. And what this found was that 30% of patients achieved normal urinary free cortisols, so normalised their biochemistry and their cortisol levels, and they had an improvement in all the clinical outcomes, including blood glucose, HbA1c as a measure of glycemic control, their cholesterol and lipids, body weight and BMI all improved with normalisation of the cortisol with the use of this medication. Of course, there's always some adverse effects. I suppose the main thing to mention about this medication is the risk of liver-associated adverse events, because that can be a limitation to using ketoconazole, which is the medication similar to this one, and there was a much lower sort of rate of liver-associated adverse events, and none of them were serious. So what they saw was typically a sort of transient rise in liver enzymes, which didn't result in any serious outcomes. That's quite recent, and I suppose I think there's things in process now to make that available, but that's been in development at the moment and quite promising. This is another medication, osilodrostat, also similarly targets the cortisol production in the adrenal glands by inhibiting the enzymes in the adrenal glands. There's been a couple of trials looking at the use of this, which is really very promising. A phase 2 clinical trial showed that 84% of patients at 10 weeks and 79% at 22 weeks achieved normalisation of the urine-free cortisol. So that's really quite impressive numbers. Then a phase 3 trial, which was following up on the initial trial, looked similarly at the urine-free cortisol. So patients who had already been on some sort of treatment and had normal cortisol levels were then randomised to continue on the medication or to change to a placebo. And what they found that was the patients who continued on the medication, 86% of those patients versus only about 30% of the placebo patients continued to have normalisation of the urine-free cortisol and good biochemical control, and also improved clinical outcomes in terms of quality of life, blood pressure, weight and glucose control. So this is another very promising medication in the treatment of Cushing's. This one is quite an interesting one, which is being investigated at the moment as a potential treatment option. So this picture here is milk thistle, and what's been taken from the milk thistle seeds is something called silibinin, which basically is an inhibitor of something called a heat shock protein 90. Now what that does, the HSP90, it's actually been found to be increased in Cushing's disease, and that interrupts the negative feedback on the ACTH production in the pituitary. So when you've got high levels of HSP90 in Cushing's, you've got higher levels of ACTH production. And what happens with the use of the silibinin from the milk thistle is that actually inhibits the HSP90 and so causes a reduction in the ACTH production. So they've shown in mice that mice with Cushing's disease, there was decreased tumour growth, decreased cortisol levels, and an improvement in symptoms. Based on that, they're now sort of developing clinical trials in humans to further research the use of this in humans, with the hope that in humans it would also reduce tumour size and improve biochemistry in Cushing's disease. So that's ongoing at the moment. Finally, on Cushing's disease, I'll just talk you through the illustration up on the top right. It illustrates the outline of a cell. What's going on in all cells all the time is very, very complex pathways of cellular signalling which promotes cell growth and cell proliferation. On the outside of the cells there's a number of receptors, and certain growth factors stimulate the receptors which then trigger the intracellular signalling pathways to cause cellular growth, and in tumours to cause tumour growth. One of these receptors is epidermal growth factor receptor, which responds to epidermal growth factor, and that has an important function in cell survival and proliferation. But what's been seen in a lot of different cancers and also has been explored in Cushing's disease is that there's an increase in EGFR receptors, or perhaps mutations to the EGFR receptors, which basically increases the cellular signalling and the cellular proliferation. So this is now a target in a number of cancers such as lung cancer with really, really promising effects. In Cushing's disease, the EGFR, the receptor, is highly expressed, and there is an association with more aggressive tumours in Cushing's disease, and it increases the ACTH production. The thought was, well, if you can target it, and we do have the medications to target this, which have been used in other cancers, then perhaps that would be effective in treating Cushing's disease. Once again, my studies have shown a reduction in ACTH secretion and a reduction in tumour growth with the use of inhibitors of the EGFR. So that's very, very promising. Human trials are needed to investigate this further, but that is possible. These drugs are being used a lot. We know about the side effect profile, and these things it's another medication that's being looked into at the moment. Craniopharyngiomas. Again, I've got a similar pathway here, and I'll explain why that's important in a moment. But once again, growth factors stimulate the receptors to initiate this intracellular signalling pathway, causing cellular growth. In terms of craniopharyngiomas, why that is relevant, there's two main types of craniopharyngiomas. There's the adamantinomatous craniopharyngioma, and there's a papillary craniopharyngioma. And what's been looked at recently is the presence of BRAF mutations in papillary craniopharyngiomas. The BRAF oncogene is along this cell signalling pathway, and when that's mutated, what can happen is that there's interruption to the normal cell signalling pathway and increased signalling and over-proliferation of the tumour cells. So it's been found that this BRAF mutation exists in craniopharyngiomas, and there's certain medications that we have available that can target BRAF and the mutations. So there's been a couple of case reports now of use in papillary craniopharyngiomas with BRAF inhibitors. So Gefitinib is what has been looked into, and that's resulted in significant reduction in tumour size. Now it is limited to case reports only, but it's a promising option. This is an illustration of one of the patients, and you can see on the left is prior to treatment. You can see the tumour here, and as treatments progress, the tumour growth, the tumour's really decreased. And down the bottom is a graph of the tumour volume, and there was sort of over 80% tumour volume reduction, so really quite impressive with the Gefitinib. Now, the last little bit of this talk, I'll talk about aggressive pituitary tumours and treatment options. So basically, after we've treated with surgery, radiotherapy, then we start looking at other options. Temozolomide is first-line chemotherapy for aggressive pituitary tumours and pituitary carcinomas. There's a couple of different dosing regimens, whether it's used in combination with radiotherapy or not. Overall, tumour volume reduction is seen in about 37 to 47% of patients treated with temozolomide, and biochemical response is seen in around 20% for complete biochemical response in functioning tumours. In terms of adverse effects, headache, nausea and vomiting are probably the most common. There is a potential for bone marrow suppression, so we need to monitor cell counts. MGMT is something that we measure which may sort of predict response to temozolomide, and that's something that we measure in the tumours, as Nell was talking about before, how we sort of analyse the tumour histopathology. So that's temozolomide. I won't dwell on that too much because that's a whole subject in itself. What I would like to talk about is what we do after temozolomide. And again, we're getting back to this intracellular pathway because that's where a lot of the research and the new medications are targeting. There's a few different options to target different parts of these pathways. There's two main pathways which are stimulated by the receptors binding to the growth factors. Both of these pathways end up in the final point of it is something called mTOR. And there's been a drug that specifically targets mTOR as the endpoint of these pathways, and that's called everolimus, and that's used in a number of different conditions and has more recently been used in select case reports of pituitary tumours. So there's no sort of big trials going on with the use of this, but it has been used very effectively in a number of cases of aggressive pituitary tumours. Some patients have responded extremely well and others not so much. But it is a very interesting area of ongoing research. There are other tyrosine kinase inhibitors. These medications, particularly Gefitinib, sunitinib and erlotinib, they actually target, so once the growth factor binds to the receptor, that stimulates the tyrosine kinase receptor, and so these medications block the pathways up at the level of the receptor interaction. And there's been one successful case report of these medications and a handful of others with varying results. Bevacizumab is a VEGF inhibitor, and VEGF is a type of growth factor that can bind to the receptor and then stimulate intracellular signalling. And once again, there's mixed reports of response with the use of bevacizumab, but it has been used effectively in a handful of patients, sometimes in combination with other treatments like radiotherapy and chemotherapy, but there's been about 2 cases where it's been used on its own with some effect which has been durable up to several years. So that's another quite promising medication in the right circumstances. Just briefly, I'll talk about peptide receptor radionucleotide therapy. This is a nuclear therapy which where there's an isotope which actually binds to the somatostatin receptors, which I mentioned earlier on, and these are expressed by the tumour. This therapy, there's about 14 case reports in my most recent reading. Once again, variable response. 2 of the patients in these reports had significant tumour shrinkage. 3 patients had stable disease, which in some cases is a good outcome. You know, if you've got tumours that are growing and you can stabilise it, that's a good outcome. 9 of those cases did unfortunately progress on treatment. So still it's unclear exactly what the role of this therapy is, but it has been explored and continues to be explored. Finally, what I'd like to mention is the use of immune checkpoint inhibitors, which I think is a really fascinating area, and this is what I'll be looking into my PhD project, and we've got some work going on at the Garvan looking into this. So immune checkpoint inhibitors, they're monoclonal antibodies that target the immune system in cancer, and they're being used in lots of different cancers at the moment with really remarkable results. So melanoma, non-small cell lung cancer, renal cell carcinoma, squamous cell carcinoma, lymphoma, urothelial carcinoma. They've really changed the face of cancer treatment and are really quite incredible. What they do is manipulate the immune system. So under normal circumstances, the T cells in the immune system are responsible for fighting the tumour cells. T cell activation requires co-binding with other receptors on antigen-presenting cells or tumour cells. So there's a few different sort of messages going to the T cell that requires stimulation to activate the T cell. the same receptors that can upregulate T cell activation can also downregulate T cell activation when bound by a tumour. So that's, if you look at the illustration on the left, CTLA4, an inhibitory receptor, as is PD1. So they're inhibitory receptors in the T cell, and when they preferentially bind tumour cells, it downregulates T cell response. So the idea of immune checkpoint inhibitors, or the antibodies, they're antibodies directed against PD1 and against CTLA4, and so they actually block the inhibitory signalling of the T cells, and instead of down-regulating T cell activity, they up-regulate T cell activity and make them much more effective in fighting the tumour cells. So really very clever. Every day there's more options coming out, they're being developed all the time. So this is a case that was published towards the end of last year. It's the only case published so far, although we have some experience ourselves. And this was out of a 35-year-old female who had a very aggressive ACTH secreting adenoma that initially responded to chemotherapy but then unfortunately metastasized to the liver. This patient received combination ipilimumab and nivolumab, which are two of the immune checkpoint inhibitors, and this resulted in a significant reduction in both the intracranial tumour, the liver metastases, and the ACTH. So you can see here the intracranial tumour up the top and the liver tumour up the top prior to treatment, and then following treatment, significant reduction in tumour size. ACTH was up at over 10,000 pre-treatment and dropped right down to normal levels with treatment. So really very remarkable response. And as I said, we've got some experience with it at our centre here, and that's an area that we're researching and looking into a lot more as I think a very promising and very exciting area. That's all I was going to cover. Basically, some of the new and emerging treatments in different types of pituitary tumours, some more established than others, but a lot of really exciting research going on and some quite promising options for the future, hopefully. Thank you.